Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. It is the policy of Medscape Education to avoid the mention of brand names or specific manufacturers in accredited educational activities. However, trade and manufacturer names in this activity are provided in an effort to provide clarity. The use of brand or manufacturer names should not be viewed as an endorsement by Medscape of any specific product or manufacturer.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hi, welcome to this Medscape Global Oncology program called Patients Progressing on an AI plus minus CDK4 6 inhibitors from biomarkers to treatment strategies. My name is Nadia Harbeck. I'm the director of the Breast Center at the LMU University Hospital in Munich, Germany, representing the European viewpoint. And I have a wonderful colleague here joining with me. Manali, why don't you introduce yourself?
Great. Hi there, Nadia, and hi all. My name is Manali Bave. I'm a breast medical oncologist and also director of the Phase 1 Clinical Trials Unit at Winship Cancer Institute of Emory University in Atlanta, Georgia, and happy to be participating today.
Wonderful to have you, and I hope that we'll exchange also some viewpoints, what we do in Europe, what you do in the US. I think you have a couple more approvals, but we'll get to that. So in this program, we'll discuss the following: the current guideline recommendations for first-line treatment of ER-positive, HER2-negative metastatic breast cancer, then what is the algorithm for detecting mutations to determine second-line treatment after patient progresses, the importance of testing for ESR1 mutations, oral SERDs, and how they're going to shape the treatment landscape and are already shaping it. And then we'll look at future directions. So let's look at the current landscape. What do we do? What do the guidelines tell us in ER-positive, HER2-negative metastatic breast cancer? If you look at the FDA and EMA approvals, and some of the latest approvals are only by the FDA, and hopefully Europe will follow very soon, we see that there's always been a large gap between the 1970s, 1980s with tamoxifen, then we had fulvestrant in the early 2000s, then we had these targeted agents that sort of helped us to combine and get more response in our patients, with everolimus starting, then the CDK4/6 inhibitors, capivasertib, elacestrant. Now we have imlunestrant, which is still only approved in the US. And then we had the AIs, we had fulvestrant at the now used dose, and obviously also some of the PI3 kinase inhibitors. So always a large gap in the beginning, but now things are really moving fast. And this is just the endocrine-based treatment options that we have in this setting. If you look at the first line, there has been a recent change due to the approval both in Europe and the US of inavolisib, PI3 kinase inhibitor. So we now have to see the patients that come in with first metastasis in ER-positive, HER2-negative disease whether the metastasis occurred while on adjuvant treatment or within the first 12 months of completing adjuvant endocrine therapy, or whether it's a recurrence that is further out, or whether there has not been previous AI exposure or de novo metastatic situation. If it's a long time after completing adjuvant AI, we would recommend to go for another AI-based treatment together with a CDK4/6 inhibitor, and then we'll get into the second line very soon. If the recurrence comes very fast on adjuvant AI or within 12 months, then we need to test here for the first time, test for PIK3CA mutation. You can do in the tumor tissue or in the liquid biopsy, and then we can use inavolisib plus palbociclib plus fulvestrant. The rationale behind this treatment modality is the INAVO120 study, which was published last year in the New England Journal of Medicine, where we saw substantial improvement in progression-free survival with a hazard ratio of 0.43 of the triplet combinations in tumors with a PI3 kinase mutation over the doublet of just fulvestrant plus CDK4/6 inhibitors. So on October 10 last year, 2024, inavolisib was approved by the US FDA in combination with palbociclib and fulvestrant for this treatment indication following the INAVO120 study. In Europe, the approval was more recently, but now we're also able to use it. And at ASCO this year, we saw presented by Dr. Turner, we saw the overall survival data from the INAVO120 study with a hazard ratio of 0.67 and an absolute difference of about 7 months, so more than half a year in median. So very effective triplet combination prolonging survival in those patients with a very short interval after or relapse on adjuvant endocrine therapy. The second line after patients have progressed either on this triplet combination or on their endocrine therapy plus CDK4/6 inhibitor, here we need to do biomarker testing again. We need to look at ESR1 mutations. We need to look at PIK3CA mutations. We need to look at AKT pathway alterations, which is mostly PIK3CA, but also includes AKT or PTEN alterations. And then obviously, if there is no actionable mutations, we can still go to endocrine monotherapy or exemestane or any other endocrine therapy plus everolimus. Let's look a little bit more closely in what we can do therapeutically in patients with mutations. There is mutations, obviously, they go beyond the HR positive, HER2 negative breast cancer situation. We have germline BRCA testing, germline PALB2 testing. If that is their mutation found, we can go for a PARP inhibitor. And then we have these tumor agnostic indications, which are very rare, but can also be sometimes found in breast cancer, like NTRK fusion or MSI high status, for example. But more importantly, I think for breast cancer, because they're much more frequent, obviously, are the PIK3CA activating mutations, the AKT pathway alteration, or the ESR1 mutation. And if you look at the endocrine resistance, which could be mediated by growth factor signaling and then also by ESR1 mutations, but then also downstream the pathway, we have basically targeted agents targeting all parts of this pathway, including mTOR inhibitors, which don't need a biomarker, but still are very active in this second line setting. And if we have an AKT pathway alterations, which is for the majority a PIK3CA mutation, then we have the options of using capivasertib plus fulvestrant in this setting in patients who had progressive disease after AI therapy. And we see here from the Capitello study actually efficacy in both in the overall cohort as well as in the AKT pathway altered tumors, but in the AKT pathway altered tumors, the effect is more pronounced. So this is where the approval is with a hazard ratio of 0.5 for progression-free survival, and we're still awaiting the final overall survival data from this study. And with that, I hand over to Manali, and she's going to take you to the ESR1 mutation detection as well as the therapeutic consequences.
Thank you, Nadia, for that really nice overview. We're going to switch gears now to ESR1 testing, and this was actually our first phase 3 looking at a shift in the treatment paradigm of detecting the emergence of molecular endocrine resistance to guide actually a switch in therapy prior to radiographic progression. And SERENA-6, again, was a phase 3 study that was presented at ASCO 2025. So in this study, patients who had received at least 6 months or more of first-line CDK4/6 inhibitor plus an aromatase inhibitor were eligible, and a little over 3,300 patients were screened in this study. They then underwent ESR1 mutation surveillance, which was ctDNA that was assessed every 2 to 3 months to detect an ESR1 mutation. If an ESR1 mutation was detected, patients also had scans at that time, and if no evidence of radiographic progression, so again, this is purely molecular progression, those patients were then randomized, so that was about 315 patients, randomized to a switch in their endocrine therapy from an AI to camizestrant with continuation of their CDK4/6 inhibitor versus continuation of their standard of care therapy, which was AI plus their CDK4/6 inhibitor. And in this study that was presented by Dr. Turner, we saw that it was a positive study with an improvement in progression-free survival of approximately 16 months in the patients who had switched to camizestrant at the time of molecular resistance versus 9.2 months in PFS for patients who had stayed on their aromatase inhibitor plus CDK4/6 inhibitor. And we actually saw that improvement in PFS across multiple subgroups. The PFS2 data was shared and was numerically longer, but did not show a statistically significant difference yet. It's still immature, as is the overall survival data. So I do think that this is and may become a practice-changing shift in treatment paradigm, although I do think a lot of us are, one, waiting for the approval of camizestrant, but two, waiting on some of that additional clinical outcome data, including overall survival and PFS2, prior to making this change. An important point to also note is that there were some patient-reported outcomes that were presented, and it did show that quality of life was maintained for longer in patients who had that early treatment switch to camizestrant. So we're going to do a little bit of a deeper dive into ESR1 mutations, which is an acquired mutation. So there are multiple mechanisms of resistance to endocrine therapy, and Nadia had discussed the PIK3 AKT pathway alterations, but we also see that approximately 40 to 50% of patients develop an ESR1 mutation, which essentially leads to constitutive activation of the estrogen receptor, making that tumor independent of estrogen, and therefore making aromatase inhibitors less effective. We see that the prevalence of ESR1 mutations being an acquired mutation increases after exposure to endocrine therapy. Interestingly, in patients who have received adjuvant endocrine therapy, the prevalence of an ESR1 mutation after adjuvant exposure to endocrine therapy is actually very low. It's in single digits. However, in the metastatic setting, as we get into first-line endocrine therapy, second and then third-line endocrine therapy, we see an increase in the prevalence of ESR1 mutations upwards of about 40 to 50% if checked. So one question that's come up, and Nadia, this is something I wanted to ask about you too, is when should we actually test for ESR1 mutations? As mentioned, the incidence of ESR1 mutations after adjuvant endocrine therapy, so in that first line recurrent setting or de novo metastatic setting, is very, very low, single digits. And so our current treatment paradigm is to assess for ESR1 mutations after exposure to endocrine therapy in the first line metastatic setting and then after subsequent lines of endocrine therapy. I was wondering, Nadia, if you could talk a little bit about how this testing is done in Europe as well.
Yeah, so we do exactly the same. we don't test if there hadn't been any endocrine therapy. Also, if patients come off tamoxifen in the adjuvant setting, it's probably not very likely that there will be an ESR1 mutation. And we actually, in our ADAPT concept in early breast cancer, we looked for resistance markers, and ESR1 mutation was maybe 1% or less. So it was very, very low in the upfront setting. So we would test when it has therapeutic consequences. At the moment, we only have elacestrant approved in Europe. We are waiting for the approval for imlunestrant. So we would test, as I showed in my algorithm, after first-line therapy when there is a progression, and we use liquid biopsy to do that, and we would add the PIK3CA mutation testing there as well if we don't have that result from a tumor tissue diagnostic earlier.
Absolutely. And I think that segues really nicely into my next slide. So this was actually a retrospective analysis that we conducted looking at the detection of ESR1 mutations in tissue samples as well as liquid biopsies in the first, second, and third line setting. And interestingly, and not surprisingly, we did see that the detection of ESR1 mutations was higher actually in liquid biopsies and tissue testing. It is important to note, however, that if the tumor fraction is low in that liquid biopsy, that does significantly lower the sensitivity of the genomic testing in that sample. And so if you do find on that test report that the tumor fraction is low, typically less than 1%, then we do recommend reflex tissue testing just to ensure that you're not missing any actionable alterations. We also see that we can have co-occurrences of mutations with comprehensive genomic profiling. And in the same study, we looked at the occurrence of co-mutations, and we found that as we progress from first to third line therapy, we found an increase, about 17% co-alterations of ESR1 mutations, along with alterations in the PIK3-AKT pathway. And I think this is important to highlight because this does come up clinically. Well, which is a mutation that we should target first? Does it actually matter? And I think as of now, it really ends up coming down to, I think, pace of disease, clinical factors, looking at the toxicity profiles, which are very different between the oral SERDs versus the PIK3-AKT inhibitors, and patient provider preferences on which to target. But we will see some data that in subgroup analyses with the use of oral SERDs, we still saw clinical benefit with oral SERDs despite patients having PIK3 alterations. So here are currently approved endocrine agents, our aromatase inhibitors, which are typically used in the first-line setting. Tamoxifen, not so much utilized in the metastatic setting, but may be used. And then fulvestrant, which is our typical second-line endocrine agent that's used. However, there are some limitations with the use of fulvestrant, namely that we see very limited efficacy with single-agent fulvestrant, as well as some inconvenience and local site reactions related to the intramuscular administration of fulvestrant. And this is where the development of oral SERDs has really been practice changing. It's oral, it's very convenient for patients, has higher potency. We see significant activity in patients that have ESR1 mutations, which in general, carry a less favorable prognosis for metastatic hormone-positive breast cancer. And then we also see activity of these oral SERDs in patients who have progressed on our first-line CDK4/6 inhibitor plus endocrine therapy. So here is a really nice summary of the novel endocrine therapies that we have some approvals for and some are in development. And the two that we've highlighted today are elacestrant per the EMERALD study, which we'll get to in just a moment, which is approved as monotherapy after progression on one line of endocrine therapy, as well as in the US, the approval of imlunestrant also as monotherapy, but we do have combination data with abemaciclib as well in patients for both of those oral SERDs in patients with metastatic hormone-positive breast cancer with ESR1 mutations. We've also seen some data and emerging data on selective estrogen receptor modulators, as well as other endocrine agents, including our PROTACs, SERANs, and estrogen receptor degraders listed here. And I think one of the big questions that's going to come out of that table that I just mentioned is how do we sequence these agents? And outside of ESR1, are there going to be any additional biomarkers that we can utilize to help with selection of therapy? So let's do a deeper dive into oral SERDs. What we know about ESR1 mutations is that in patients who develop this acquired ESR mutation, it's associated with significantly poorer prognosis, and we see a sudden drop in survival related to the acquisition of an ESR1 mutation. However, as mentioned, we do have oral SERDs that work quite effectively in patients that have this mutation. So here's a nice overview of the Kaplan-Meier curves with 3 of our oral SERDs. Emerald showed a nice progression-free survival of 8.6% versus 1.9% with monotherapy elacestrant, particularly in patients with ESR1 mutations, but who had also had sensitivity to prior CDK4/6 inhibitor for at least 12 months. In SERENA-2, looking at camizestrant, we also saw an improved progression-free survival of 9.2 months versus 2.2 months. And then EMBER-3, which was looking at imlunestrant, we also saw a progression-free survival improvement of 5.5 months versus 3.8 months. Again, all of these oral SERDs showed activity in patients, particularly with ESR1 mutations and who had seen prior endocrine therapy. So I'm going to just briefly go through this, but we have the FDA approval for both of these oral SERDs, again, in patients with ESR1 mutations with hormone-positive, HER2-negative, advanced or metastatic breast cancer who have seen at least 1 line of endocrine therapy. And I hope that in Europe, you'll shortly see the approval of imlunestrant as well. So there are still patients, however, who tend to have a drop in their progression-free survival related to a lack of endocrine sensitivity. So those are patients that have endocrine-resistant disease and don't tend to respond well to 2nd or 3rd line endocrine options. And the question has become, are there combination strategies that might allow us to resensitize tumors to endocrine therapy? Combinations with either 2nd CDK4/6 inhibitors or potentially our targeted inhibitors, including alternative PIK3, AKT, or mTOR inhibitors. So here's another slide looking at other markers that we can utilize to determine benefit from oral SERDs. And this is a post-hoc analysis of the Emerald study, looking at prior time on CDK4/6 inhibitor as a surrogate marker of endocrine sensitivity. And what we found is that patients who had seen at least 12 months of CDK4/6 inhibitor plus AI prior to progression had improved progression-free survival with the use of monotherapy elacestrant compared to standard of care endocrine therapy. And this is typically the benchmark that we utilize when we're thinking about use of oral elacestrant. We also saw some data from EMBER-3 that perhaps the combination of abemaciclib plus imlunestrant can actually improve progression-free survival, particularly in those patients that might develop some endocrine resistance. And what we found is that in EMBER-3, in patients with ESR1 mutations, the progression-free survival with the combination of abemaciclib plus imlunestrant increased to 11 months compared to 5.5 months with monotherapy imlunestrant. And I think that's a question that comes up a lot. In which patients might we consider monotherapy endocrine agents, or are we just going to see improved benefit with combination therapies? In general, I would say the safety profile of oral SERDs are very well tolerated, and we've actually had a couple of these trials open at Emory, and so I've had personal experience. The most common all-grade side effects that we see with elacestrant are some GI toxicities, namely nausea and vomiting, but as well as some fatigue and arthralgias. With imlunestrant, slightly different profile, but again, nausea, fatigue, and then some mild diarrhea. And then we see actually some unique toxicities with camizestrant being photopsia or visual changes, which are just flashes of light that you can see, typically low grade and not bothersome to the patient, as well as bradycardia. So again, fairly well tolerated oral SERDs, but with unique safety profiles amongst them. Then we discussed already the presence of co-mutations, but this was another publication, a retrospective review, looking at the percentage of patients with PIK3 or AKT mutations who also had a co-alteration in ESR1. And we saw that approximately 37% of patients with PIK3, AKT, and or PTEN alterations also had a coexisting ESR1 mutation, which brings us back to the question of which to target first. Does it actually matter? Are there any additional biomarkers and or clinical characteristics or perhaps the toxicity profiles of the drugs and patient comorbidities that we should consider when making the decision on which to target. So, Nadia, I wanted to actually speak with you a little bit about co-alterations and what your clinical take has been when you see a patient that has both a PIK3 AKT alteration and an ESR1 mutation.
Yeah, I think we're talking now about the second line treatment and just exclude those patients with the very rapid progression after adjuvant, because if they have a
Correct.
big 3CM mutation, we would go down the Inavo 120 route, basically. But if you come to second line, we have co-mutations. I think we would look at the clinical course of disease, at the patient profile, see what side effects the patient would be willing to tolerate, what is sort of how we can manage the therapy together, how often the patient wants to come, etc. So and in patients with a very indolent progression, just gradually progressing, I think a monotherapy with an oral SERD is a perfect therapy, because the patient doesn't have to come in so often, there isn't that much monitoring to do, and the quality of life is excellent in those patients. Whereas if we have the feeling like there is a lot of visceral burden, and this may be our last try to get an endocrine based combination in, and we have the feeling that the disease has some speed and is picking up speed, then I would go for a combination treatment. And um I mean, honestly, now we have, as I said, in Europe only elacestrant available, imlunestrant you also have as a monotherapy available in the US. I think these SERDs are also optimal as combination partners for all oral combinations. So that may be in the future, but for the time being, I think we would go the way indolent disease, elderly patient, low management activity on our part. I would just pick the oral SERD if there's a co-mutation.
Yeah, I agree with you. I oftentimes take into account the clinical characteristics, patient baseline factors like age, functional status, comorbidities when making that decision. I do think that what's been helpful, particularly in the US, is knowing whether a patient has a PIK3 or AKT mutation up front so that I can be considering how to optimize perhaps their diabetic control for future use of a PIK3 or AKT inhibitor. But I agree when the time comes that we're making a decision on which to target, it often comes down to, again, those clinical factors that you were talking about, because we do see benefit with both types of inhibitors, the combination PIK3 versus oral SERDs in patients that have co-mutations.
Yeah. You just showed these SERDs with regard to their side effect patterns, but uh, is there any data on which oral SERDs show most potential for CNS meds?
It's a fantastic question, and we haven't seen a lot of that data yet. I think, a lot of it will come down to combination therapies with some of the other targeted therapies that do have better CNS penetration. We do see differences in CNS penetration with our CDK4/6 inhibitors. We haven't seen a lot of that data come out of our novel endocrine agents yet, although I do think that data will be coming. But I do wonder whether we'll be looking at the partner therapy to endocrine therapy in considering combinations to use, particularly for patients that have CNS disease based off of CNS penetration of those targeted therapies.
I mean, that could be a hope for the imlunestrant abemaciclib combination once the approval extension has been granted, because abemaciclib has some activity in CNS meds and
Same.
imlu as well. So that would be exciting.
Absolutely. And as I referenced before, there have been some subgroup analyses in both Emerald and with elacestrant and EMBER-3 with imlunestrant, looking at activity of these agents in patients that have different mutations. And what we consistently see across these oral SERD clinical trials is that we are seeing clinical benefit with the use of oral SERDs despite co-alterations, including in PIK3, TP53, clinical factors like visceral disease, et cetera. And so, unfortunately, it's not all that helpful to make a decision on what your second or third line therapy will be. But I hope that we will see some additional data on biomarkers or clinical factors that might sway us in one direction versus the other.
Yeah, if you look at the co-mutations here, there is efficacy, but there seems to be some endocrine resistance there as well. So, what do you think about the data from the EMBER-3 study where they combined the CDK4/6 with the oral SERD, and it seemed like the mutations didn't seem to matter with regard to efficacy? Do you think that's the way forward at the end of the day once we have all the proper approvals to just have a combination there?
Yeah, I definitely think so. I think for me, when I'm viewing the data, I'm a bit more excited about the combination strategies with these novel endocrine agents as opposed to the monotherapy data. I think we are seeing efficacy with monotherapy SERDs, but a little underwhelmed with the response, the PFS that we're seeing, closer to about 5 months or so with monotherapy oral SERDs versus an increase to 9 to 12 months of PFS with combination strategies. And so the abemaciclib imlunestrant progression-free survival, as mentioned, was about 11 months. We're going to see some emerging data with elacestrant combinations as well, but I do think the direction of the field is more than likely combination strategies as opposed to monotherapy, except for in those select patients that are exquisitely endocrine sensitive or may have clinical factors for which combination strategies may not be tolerated.
Yeah, I mean, if you look at the data that we saw at ESMO, there will be even more new agents coming and more combinations.
So just key takeaways, because we're just at time. It's very important that biomarker testing be done and performed in patients that have hormone positive, HER2 negative metastatic breast cancer. We have several biomarkers that we have targeted therapy approvals for. Typically, we recommend that testing be started after progression on first-line therapy with a CDK4/6 inhibitor plus endocrine therapy, with the exception of those patients that have endocrine-resistant disease to begin with, who have progressed on adjuvant endocrine therapy within 12 months or on adjuvant endocrine therapy. So thank you so much for your time. And Nadia, I know if you wanted to say a couple words at the end as well.
Yeah, so thank you, Manali. That was great. The half hour just flew by, and I think I think we touched on the most important points. And thank you to our audience for doing this webinar with us. And with that, I would just like to thank you very much for participating in this event.
Thank you so much, Nadia.